Hello, welcome to the first in a series of short videos demonstrating the key components of the gastroschisis care protocol used in the gastroschisis interventional study in Ghana, Zambia, Malawi and Tanzania. In reality, the care protocol is tailored to each individual setting. I shall cover the core components in these videos. This first video is how to get the baby from birth to the tertiary paediatric surgery centre in the best possible condition. All aspects of care are aimed at trying to prevent the three leading causes of death. These are sepsis, dehydration and hypothermia, and to protect the bowel as much as possible. And you may have a protocol similar to this to follow at your centre. So firstly, when the baby is born, place it onto the mother's abdomen as normal and dry the baby all over to prevent hypothermia. During this time you can reassure the mother. You can say something like, don't worry, you've seen this condition before, you know how to manage it, and care is available. You can practice delayed cord clamping. So clamp the cord 1 to 3 minutes after delivery. This will help to optimise the blood volume in the baby and perfusion to the bowel. You can then cut the cord at 8 to 10 centimetres. You don't need to measure it, you can just estimate. But this long cord will help us to close the defect, the hole in the abdominal wall, at a later date. Then transfer the baby to a dry towel, preferably on a radiant heater to keep warm. Cover the head to prevent heat loss, either with a hat, towel or sheet. You want to prevent heat and fluid loss from the intestines as well. So cover the bowel in clean plastic. So a clean plastic bag such as this, any other clean plastic bag. You can use cling film, you can use clean plastic apron, anything you have available. Obviously you'll resuscitate the baby as required and provide oxygen if needed. Of note, it's important not to apply wet gauze to the bowel. That can dry onto the bowel during transfer, causing bowel damage, and wetting that gauze can cause hypothermia in the baby. So now you want to proceed to cannulate the baby. Of course it takes slightly longer in real life. You want to give a 20 ml per kilogram normal saline fluid bolus. So despite your measures there will be some fluid loss from the bowel and you want to prevent dehydration. You want to also give some broad spectrum antibiotics such as penicillin, metronidazole and gentamicin. This is to prevent sepsis. And you can then start 10% dextrose maintenance fluids at the normal rate for a baby on the first day of life. You can also give vitamin K as you would to any other baby. You're then in a position to insert a nasogastric tube. So measure this as normal and then add an extra 3 to 5 centimetres so that it can reach down to the stomach, which is often protruding outside the abdomen, as you can see here. You want to see that stomach deflate as the nasogastric tube enters the stomach. And you can then leave that on free drainage until the baby is at the tertiary paediatric surgery centre. Putting the end into a glove is fine. And use some strong adhesive tape to ensure that stays in position during the transfer. Now really important is to keep the baby warm throughout their time with you and during the transfer. If you have a radiant heater, keep them on that while they're with you. If not, the baby can be placed in skin-to-skin kangaroo mother care, but in a modified position, in a breastfeeding position instead, with the bowel on top of the baby's abdomen. Make sure there's no bowel dangling over the side as that can damage the bowel. But you don't want the baby outside the clothes, you want the baby inside the clothes like this so that they're skin to skin. Obviously the bowel is covered with plastic at this stage. The mother can give a 5-minute breastfeed as well. Then aim to transfer to the tertiary centre as fast as you can. Aim to leave your centre within an hour of birth or an hour of arrival if they've been referred to you. Every hour sooner that the baby gets to the tertiary centre is a higher chance of survival. During transfer, keep the baby skin to skin to keep them warm, and give a good referral to the tertiary centre detailing when you gave the antibiotics and what care you provided so that they can continue the care seamlessly when the baby arrives therein.